Hello, this is Elliot Fishman, and we're live. And I just spent the last 10 minutes washing off sunscreen from my face. I'm out in Montauk. Probably a lot of people don't know where Montauk is. Maybe people do. If you're in New York and if you go as far as you can to the end of Long Island, you're going to run into Montauk. So that's where Montauk is with my grandchildren, my daughter, son-in-law. Very nice here and very casual, and forgot to shave, and here's a mess. Just came back from the beach. I personally do hate the beach, so you can take that for what it's worth. This is I guess it's not quite the well, today's Thursday, right? It's the 24th of June. So this is going to be the last talk in June. The next talk will be July 1st. This will also be the last talk of the academic year, right? So in all residencies, fellowships, things begin July 1st and end June 30th. A number of our fellows have left already, so the ending comes quick. People go to a new job. Some people are taking off a month. Some people are taking off 2 months. Some people are taking off the weekend. So we had great fellows this year. It was a challenging year for everybody. We're still not away from COVID, but as I told the fellows at our little farewell, and of course our farewell was over a Zoom call, not in person, but as I told people that the good news is they came, we were in the middle of COVID, no one knew when COVID would be over or it would slow down. Now, at least with the vaccine, there's some hope. There's challenges, of course, with the Delta variant, and of course, as we know, more variants will come along. You need to get the population vaccinated to protect against these variants. And I'm sure probably all of you know that although I doubt we're going to have a third injection come November or October, surely in the 2022 calendar year, it's my belief that we will have another vaccine. But that's okay. I think all of us have always taken flu vaccines, which work about 50% of the time. If we can get a vaccine that prevents COVID 95% of the time, I think all of us will be very, very happy with that. So being practical, we start our new fellows next week, and a lot of the reading to date in different divisions, though less in diagnostic, has been remote. A lot of people don't want to come back, right? A lot of people have, after 17 months, have kind of gotten used to it, and their attitude is, oh no, we could do things as well from home. We could use Zoom, and we could use Microsoft, and we could use whatever else you want to use. The reality is we've learned some things work very well on Zoom. I used to run our faculty diagnostic division meeting once a month. We'd have it about 7:30 on a Thursday. Out of 20 people, we get about 12 because people were working nights, some people were working remotely, some people were busy that day. Now we do it every Tuesday. It's a little bit shorter. Instead of 45 minutes or an hour, it's 30 minutes or 35 minutes. But people feel much better informed and they want to keep meeting every week. So we do it every single week. But because it's Zoom, you can log in whether you're on nights, whether you're at a remote site, whether you're home. And so we end up getting 17 or 18 out of 20 people. So you got to say that's positive. I also mentioned before I run a conference every week. I did not do it last week, or yesterday rather. My admin, Stephanie, told me I was away, so I shouldn't do it. But we've done it every week for the past 60 weeks. And we get about 35 to 40 people a week. Some people are remote. I used to run the conference every other week, very similar. I didn't quiz people quite the same. But we'd end up with 10 people because it was only for faculty. It wasn't for fellows and residents. And the fellows, in their farewell addresses, a number of them commented they liked the quiz or the case thing. And the way I do the case, as I mentioned, is we quiz the faculty. And there's something people do like about quizzing faculty. And I can see, I'll say it wrong, but Manvendra Upayaha, who's from Nepal, is in Nepal, was saying he loved the great cases we showed. And remember, every third Thursday, I'll show a series of cases that I used at our conference. So I think that's a good thing. But I think in terms of our division, we spoke about this the other day, and we've been talking about it for a while, that even now, but surely come July 1st, everybody will be in person. So we'll be wearing masks in the reading room. We assume everybody's vaccinated. You really can't ask, though I will admit that you'll know for sure because Hopkins has declared that you cannot have a position, and this is true for doctors, technologists, cleaning people, escorts, you name it. You cannot be, unless you have some medical reason, you cannot work at Hopkins unless you're vaccinated. So it has to be done and finished by August 1st. So that'll give you a little bit more comfort perhaps. But I think even though I know that the faculty, and we could ask, I guess, is all vaccinated, most people still feel that when you're in a closed space, in a reading room, we have the distance about 6 feet apart, but I still think most people are wearing masks. And Hopkins, by definition, requires masks. People will be careful where they eat. They'll probably go to their office. They're not going to eat in a reading room. We don't want you to eat in a reading room, right? So it's things like that, that things will slowly come back, but I think it's a mistake if you believe that everything will come back. And you can see in Israel now, Israel had the highest vaccination rate. They did it first. As of maybe 2 or 3 weeks ago, they went back to normal. There was no restrictions indoors or outdoors or anywhere, but the numbers have picked up significantly. And the person responsible for healthcare in Israel was talking about indoor masking. That was about 3 days ago. So we'll have to see specifically where that goes. So it's, I think we're doing better. But I just want to remind everyone to be careful because it's not cured, right? We're still going through all sorts of issues. Again, one of the things I like about Facebook Live, a lot of more people watch Facebook Live. We get about 3,000 to 10,000 people will watch it, but for a lot of people, 12 o'clock on a Thursday is not great. If you're on the West Coast, it's 9 a.m. If you're in the Middle East, it's 11 p.m. or 12 p.m. So people do watch it as it goes on, but you could see Saeed Kafadi is saying hi from Honduras, so everything with it. So we say hello there as well and hope, I think they were doing a little bit better in terms of the COVID numbers. Now, I was supposed to speak today about liver metastasis, so just to make the point and focus more on protocols, the protocol for liver mets, we do not do non-contrast CT. There used to be a lot of work. People would do non-contrast scans routinely of the liver, but really the additive effect is really none. I don't think you do well by adding non-contrast. It just doesn't really improve things. The question then is, do you do dual phase imaging? I think that's going to depend on what tumor you're dealing with. If you're dealing with colon cancer, where the mets are best seen on venous phase, where the mets are not vascular, in fact, on early phase imaging you may miss lesions, you just need a venous phase for looking for metastasis. Now, sometimes you would want a dual phase if the surgeons are going to do partial hepatectomies. Then the arterial mapping becomes very important. So you really have to think of it that way. If you're going to do arterial mapping, and you need that for surgical planning, then of course, you would want to do that. But if you're just saying, let's look at mets, you want to do venous, you want to do it about a 70-second delay, depending on patient size, roughly 100 to 110 cc's of contrast, injected 4 to 5 cc's a second. That works out very nicely. It's also a very good protocol for repeating consecutive studies so that you're able to look at progression of disease or response of disease. On the flip side, if you're doing tumors that are vascular, if you're doing metastasis from carcinoid tumors, any neuroendocrine tumor, typically the best visualization is going to be arterial phase because the lesions are hypervascular. And so in that sense, I would say do arterial phase and then do venous phase, because sometimes some lesions will show better in venous, and then you'll do both. I will not do arterial phase only, because the other thing that people do want to know is patency of the portal venous system. So if you have a tumor that's vascular, neuroendocrine tumors, which carcinoids are part of, you want to be doing dual phase. Breast cancer is always a tricky one because breast can be infiltrative. people have written articles that breast is one of the tumors that if you only do venous phase, you can miss. So surely, at least on the initial study with breast cancer, I would make sure I do dual phase imaging, where I do both arterial and venous phase imaging. And I think that ends up being a very good strategy. Now, if you think about primary tumors, when I do primary tumors, I really want to characterize things well. And the primary tumor you worry about most would be hepatoma. Hepatoma typically is best seen arterial because it's vascular. But sometimes it's relatively hypovascular and then maybe best seen on venous phase imaging. Cholangiocarcinomas sometimes have an enhancing rim, but in general they're best seen on venous phase imaging, and some people would say get delayed phase imaging with cholangios. Remember, cholangios are one of the few tumors that instead of washing out, increases contrast as you go from arterial to venous and delayed. But I think hepatoma, you need to do dual phase imaging. Hepatoma is also important to be able to look at the portal vein and SMV. It's also important to look for neovascularity. When you have an indeterminate mass, if someone says to me, I have a mass in the liver, I don't know what it is. Well, in your mind, it could be benign, it could be malignant, it could be FNH, it could be hepatic adenoma, it could be hemangioma, it could be hepatoma, it could be metastasis. If I don't know what a lesion is, then I'm going to do dual phase imaging, because then I could characterize things. Even benign lesions. Hemangiomas, yes, is probably good enough to have venous if you knew it was a hemangioma, because you have the peripheral puddling, and often arterial phase only isn't as helpful, but venous is better. On the other hand, with focal nodular hyperplasia, I can see the feeding vessel going into the center of the lesion. On arterial phase imaging, the lesion is very vascular but homogeneous, sharp borders. On venous phase, it washes out and begins to become isodense. Hepatic adenomas, which can lead to hepatoma, so it's really a premalignant condition. Hepatic adenomas can bleed. There can be difficulty distinguishing hepatic adenomas from hepatomas, and truthfully, they're going to be resected anyway. Dual phase imaging works well. Sometimes the lesions are only seen arterial phase because they become isodense very quickly. Sometimes if the patient presents with acute symptoms and you're worrying about a spontaneous bleed or rupture, then you can see active bleeding arterial phase. Typically, you don't see that well in venous phase. So again, I like to be able to think about two things. One is the detection of lesions, and one is characterization. And that's our two jobs, right? So detection is, of course, very critical. You're not going to characterize if you first don't detect things. So you need to find those lesions. Now, when I find them, I need to say, well, what are they? Sometimes you have Mets and hemangiomas. Sometimes they're all hemangiomas. Sometimes they're all Mets. So we need to look at the signature of lesions. There's a number of talks on CTisus in our, whether it's on the website or it's on our app, on the Apple Store, on YouTube, on liver mets and liver primary tumors, what the signatures are. And we make the point that you need to look at signatures. For example, we'll say that FNH, which is benign, a leave-alone lesion, is very vascular, but it's only as vascular as the IVC. It's never as vascular as the aorta, while a neuroendocrine tumor is typically as vascular as the aorta. FNH also is homogeneous. Neuroendocrine tumors often have central scars but are very bright, and they don't wash out. So when you look at the venous phase, they may be less well defined, but they're irregular both in terms of borders and the central characteristics. FNH, remember, a central scar which has a feeding vessel and can become isodense. Now, if you ask me, when do you do delayed phase imaging? And delayed typically means 3 to 4 or 5 minutes out. Some people will say for cholangiocarcinomas, if you suspect the lesions of cholangio, you want to do delayed phase imaging to be able to characterize it, since it increases in density over time. Sometimes if you only have very early phase imaging, hemangiomas don't have that peripheral puddling. It's too early to be that vascular. And then that filling in from peripheral to central may be best seen on delayed phase imaging. We talk about delayed phase imaging also as a way sometimes of picking up select tumors, though I have to admit colon cancer, any of the primary tumors, melanoma, or hepatomas or other primary hepatic lesions, it's just not going to say, "Oh my God, I found this better on delayed phase imaging." You're not going to say that. So I don't think it's really necessary. So it's really those two phases. Now let me see. I'm just looking at my comments side of things. So if you have a comment or a question, now's a good time to ask. But I see Jamie is home in Glen Burnie, has a day off, so that's good. And Carlos Espinoza is saying hi from Mexico. So we really are covering different continents today. But I think liver mets is just one of the biggest challenges. Now, if you ask me, why do people miss liver mets? Well, sometimes they're too small, that's possible. Sometimes they're infiltrative and you don't see them. Sometimes they're on the capsule, particularly things like pancreatic cancer. The mets are small, which makes it hard, but they're on the capsule. So if you're only looking at this in the liver, you may not see them. So it's very important to also be careful to look at the capsule. So what I try to do is, when I scroll through the data, look at the edges of the liver. You may see implants there. People have tried doing things like cinematic rendering, where you have the capsule of the liver opaque. That may be a good way of doing it. I haven't really seen an article that has definitively defined that. But I think that the other thing that people bring up is, how do you look at the images? So thin sections, reconstruction, coronal and sagittal are mandatory. Coronal is particularly helpful. Sagittal may be less helpful, but it can be helpful on things at the surface of the liver, or if you worry about partial averaging. So I also have done a lot of 3D. 3D is very good for vascular mapping and planning surgery. So you have arterial 3D mapping and you have venous 3D mapping. We've done a lot of work with cinematic rendering. That can be something that's very additive. So that's all things that you want to do. We've also done some work with augmented reality with HoloLens, looking, can that help with surgical resection? HoloLens is cool. It's not going to help if you're giving chemotherapy, but if you're thinking about doing wedge resections, and surgeons are more aggressive these days, that may prove to be very valuable. So let's see what else. This is a good time for questions. Let's see, we have a few hellos from Adele Robana, who's from Tunisia. And then we have John Biakino, who's coming all the way from CT. So we have a spread of people across continents, across universes, and people working hard. So if anyone has any questions, let me know. There is a couple new talks on the liver. I think they're coming out in July or early August, looking at optimizing lesion detection. So we tried that. Mataverta talks about that in Nepal because of poverty. Ultrasound is the modality of choice. Ultrasound is very good with the right tumors, but it's more of a challenge. I think there's no doubt state-of-the-art CT is better than even state-of-the-art ultrasound. But if you only have ultrasound, you need to do that. I think we are working, the manufacturers are working on how to make scanners cheaper, how to make things more available. So hopefully, regardless of where on earth you are, patients will get the best treatment. But if you can't do CT, you can't do MR, do ultrasound. People then ask me, since we spoke about contrast CT, what if a patient is allergic to contrast? What do you do then? Well, then you could do MR, or you could do ultrasound. Typically, you'll do MR. There's also a lot of work looking at PET CT. PET CT can be very valuable. Also, typically you're doing PET CT as part of a whole body workup when you're looking at certain tumors like melanoma, sometimes colon cancer, lung cancer. So PET is very accurate. PET does have some false positive, false negative, so it's not perfect, and size is usually around 1 cm. So I think there are a lot of good ways of looking at the liver. CT seems to be the mainstay of everything we do because, as you know, CT will look at all of the organs, will really give you a good feel. Mataverti makes the point that breast cancer is challenging. Breast is challenging in ultrasound, but also in CT and MR, because breast often gives you infiltrating metastases. They can give you target signs, they can give you necrotic lesions, but it can be infiltrating. Remember, patients with breast cancer who get chemotherapy can get pseudocirrhosis. And then with pseudocirrhosis, the liver looks really poor, and it's very hard to look for metastases. So breast can be a challenge with any modality. Sometimes MR is helpful in that regard. So it looks like I've done 20 minutes, and I'm out here another day or so, but hope everyone gets a little bit of time off this summer. I think this is my time away. Haven't been away in like 17 months or something like that since February 2020, and I didn't go very far, and I didn't take a plane. It's interesting. So we're in Montauk. It's outside, but except for ourselves, I've seen like one person wear a mask, whether it's child or adult. So people really, when you travel now, people are not wearing masks. Now the truth is, I think that's what what's been recommended, right? Outside, you don't need a mask, and now places like New York, Connecticut, Vermont have said you don't need a mask inside. So it's interesting that people who have been very careful the past 16, 17 months have a harder time trending back toward normal. Most people, if they really had difficult time following the rules, once the rules became a little bit easier, they jumped on those new rules. So I was in Montauk, I was in East Hamptons, I was in Armadillo, no, I don't know, something Arma something or other, Amagasit or something, really nice town. But nobody was wearing masks, and even when I went into a bookstore with the kids, even the people in the store weren't wearing masks. So I think depending where you are, and if you travel this summer, that's what you're going to see. Just the last thing, let's say hi to Anders Eichhorn from Denmark and Adele Rabana, again, thanking us. And with that, this will be online. You could watch it again if you have any questions, but take a look at our protocols, take a look at the cases we have on the teaching file, thousands of cases, and take a listen to a couple of the talks I've given on liver that are on CTisus. And with that, have a great day.